Customizing keratoplasty. Where does penetrating keratoplasty stand in the world of layer transplants today? So we'll start off the proceedings with penetrating keratoplasty. How do we assess a patient for the surgery, and what we do and what we need to be aware of? A simple outline for this talk is we assess any corneal opacity for penetrating keratoplasty. What are the anticipated complications and how do we anticipate them by our pre-op assessment? What surgery do we advise? Intraoperative procedures, investigations, and we had a quick survey with corneal surgeons and the results are the same. So there are 4 opacities that you can see on your screen, on the screen right now. 3 out of these 4 are obviously vascularized opacities, and each of these opacities require a different approach. And just looking at these opacities, you might not always be able to anticipate what trouble you're going to get yourself into, but you can always try and anticipate that trouble, and anticipating the trouble is half the battle won, according to me. So we look at this one picture where we have an inferior vascularization that is seen, but if you look at this in the retro illumination, you realize that there is not just a single vessel that is coming in, but there's actually loops of vessels throughout the opacity, and probably something needs to be done for the vascularization in this opacity before we plan anything for this patient. We really need to explain to the patient why we need to do this, and thankfully for us in this case, we were aware of the etiology and it was viral, so we were careful from the beginning. Young patient, post-viral vascularized scar, you would not want to really burn your hands with it unless really the patient understands what they are getting into. Vascularization is an important pre-op factor that needs to be assessed, not just with the quadrants involved, but the kind of vascularity that you can see. Sometimes the vascularity is just a way of the eye trying to heal itself, and in the acute stages you might want that vascularity, but once the eye quietens, really there's no use for it, and probably you would want to take steps to decrease it. So topical steroids can be tried. Etiology has to be looked into. Etiology, look for hints of viral, look for recurrent redness episodes. Probing the patient's history is essential in these cases. Argon laser vessel occlusion can be tried, and fine needle diathermy, as has been described abundantly in the literature, is also a good way of going about it. For this patient, however, we did go for argon laser vessel occlusion. When you go for this laser occlusion, probably multiple sittings may be required, not just one sitting may not be enough. If you have access to a retinal laser in your setup, can be helpful. The retinal surgeons can help us occlude the vessels. You can yourself do it, but multiple sittings of the laser may be required, and you need to assess the patient after a regular interval every time. This patient did undergo penetrating keratoplasty and is touchwood holding on well. History, I feel, is essential with every patient of corneal opacity who comes to you for surgery. Sometimes is available, seldom available in our setups. You can ask as many questions as you can. Every time the patient comes, repeat the history and jog their memory, because many a times patients recall things that they may not feel are important, but are actually very important for you, and do as many investigations as you have access to. So when to do what is important. The picture here, probably we could get away with just a cataract surgery. Looks like a long-standing old scar. The patient is used to vision with this scar and probably should not be subjected to a full thickness or even a lamellar keratoplasty. This one, on the other hand, has undergone several times PTK twice or thrice. We still were foolhardy enough to actually try a superficial keratectomy and only phacoemulsification. We did get away with the phacoemulsification, but the visual outcomes was subpar, and probably a DALC in this situation would be better for the patient. A corneal opacity, obviously we will look for density of the opacity. ASOCT is very useful. Other eye status, I feel, is very important when assessing any patient for corneal transplants, because if you explain the risks to the patient and the other eye is all right, probably patient would not be that that willing to take that risk. But if it's a single-eyed patient, you yourself will be more motivated to take the risk that is involved. Age of the patient, the risk of rejection, preoperative vision and the potential for vision. So IOP assessment and probability of secondary glaucoma has to be understood. Then there are these kind of patients who come to you and you look at this eye and you feel that there is something wrong with the IOL here. Obviously it is not stable, it's an unstable IOL, but apart from that it looks small. It's not that the IOL is small, but the eye is too large. This was a white to white of 13.1 millimeters. This patient underwent IOL explantation with SFIOL first and followed by a DSEC. So we need to tailor our treatment options as the patient demands and as the eye demands. This eye looks like a straightforward adherent glaucoma, has a small nasal pterygium. It looks well healed and corneal sensations are intact. I feel like probably we would want to operate. But when you do the fluorescein staining, you see a very prominent and active Seedal's test positive here. And you would want to actually go for an earlier surgery, but having said that, we need to assess the posterior segment as well. Sometimes these patients can have choroidal inflammation, anticipate secondary glaucoma, and till the time it's a flowing aqueous, most of the times there's no infection, but you would not want to take the risk and probably seal the eye as soon as possible. Investigations are important. Two of the investigations that I really consider essential are ASOCT and UBM. Sometimes ASOCT is able to tell you, like in this case, which was a chemical injury, and there is an endothelial dysfunction which is causing this concavity at the endothelial level. You would want to plan a full thickness graft in this eye and not a lamellar keratoplasty. UBM can show you the IOL and IOL related problems that you may have to look at before you plan a combined procedure or probably be ready for a combined procedure with a vitrectomy. Fluorescein staining, as we have shown already, Seedal's positive cases will require urgent intervention. Schirmer's will be able to give you a lot of information as far as tear film, stability, tears, the quantity, quality, as well as blink rate. Probably if you do the Schirmer's yourself, there's a lot of information apart from just the number that you get from the Schirmer's that is essential and must be noted. We took a small survey with corneal surgeons across the country, and we asked these surgeons the following questions, and we have a few results, and I would like to share those with you, and because these results are quite telling as to what all we need to look at. So when asked what do you consider most important while assessing a patient for PK, we got the most common response was etiology of corneal opacity. In a country like ours where documentation can be sparse, it is difficult at times, but if you are practicing in a place which has been around for a while, probably you will have some documentation. Fellow eye status is also extremely important. Anterior chamber depth, anterior chamber status of patients is essential. Also at this point, I would like to mention that probably you would like to also assess your own skills at that point. Maybe the world's best surgeons are doing DMEC for a particular case, but if PK works better in your hands, I suggest you go for PK. Limbal status, vascularization and corneal sensations, I think are highly underrated but very important points to be thought of. Blink rate, especially lids, and their health is also something we need to take into consideration. Complications we are most concerned about are obviously going to be rejection. And after that, people were concerned about glaucoma, something we are going to be touching upon in this session. Infection, even though dreaded, is thankfully not that common. And with the superior drugs and better understanding of hygiene, patients do well. Epithelial healing, according to me, is something that has to be thought of prior to surgery, and corneal sensations, tears, and the kind of opacity, etiology, all these things will give you a hint whether epithelial healing is going to be good, poor, or probably something you need to do something about. What factors do you base depends on the age of the patient, the etiology again, corneal opacity density, which will decide whether lamellar keratoplasty will work better for this patient or a full thickness graft is required. Intraoperative concerns are well known to us. And factors which decide the sizing of your graft, most importantly, corneal opacities. My take-home message is on the screen. Always assess, reassess, take the history again and again, because patients mention new things each time. Tears, blink rate, and corneal sensations, or any kind of exposure that you may have noticed will go a long way in deciding what kind of procedure you want to add to your PK. Fluorescein staining, the status of the limbus, any ocular surface disorder, and IOP assessment. If you are in a practice where you are going to do a lot of PKs or you see a lot of corneal scars, I suggest you equip yourself with some glaucoma assessment device, IOP assessment especially, which is appropriate for these corneal scars. Thank you so much for your kind attention, and any comments or questions? Any? Right. So going on to our next speaker.